We are trained to count the number of P waves first. Well, we do this in lead 2. And here. And we have also learned to use the PP interval to found hidden P waves. Well, there must be one somewhere here, and the same thing is true over there. So altogether we have 8 P waves here, whereas 2 of them are hidden in the QRS complexes, and we have 6 QRS complexes. This P to R ratio allows us to make the diagnosis of high-degree AB block, and since the QRS complexes are irregular, we should end up with a diagnosis of a Wenckebach phenomenon. Well, we know that in Wenckebach we should have a gradual increase of the PR interval until finally one of the P's is blocked. Well, how is this here? We see this P in lead 3 here is conducted down and makes this QRS. The next P takes much longer to come down to the ventricles and makes this QRS. The P here, which is hidden in the QRS complex, is not conducted anymore. And the next P here, again, is conducted with a rather short interval. And for the next Wenckebach phase, we have this P coming down here, making a QRS. This one takes a little longer already, making this, and this takes much longer, makes this QRS. And this one then is not conducted anymore. So in the first part here, we have a 3-2 block. And in the second part, we have a 4-3 block. So in Wenckebach, sometimes it needs some kind of detective work to find out which P's are conducted and which ones are blocked. But there's another abnormality in this case, and it is that even the conducted QRS complexes are widened. They are broad complexes, and in lead standard 1 they have this typical pattern of left bundle branch block. So final diagnosis is, this is a high-degree AV block, type Wenckebach, and with an average heart rate of about 65 per minute, plus complete left bundle branch block.